Thanks very much, Chris, and my thanks to Matt as well, and very good to be with the rest of you. I appreciate the opportunity. And effectively, in just the next few minutes, I'm going to emphasize two key things. The first is that the crucial element in pandemic management that was missed at the start, and for which we still have a considerable opportunity, is to risk stratify the population. That's going to be the crucial takeaway. But the other key thing is that you really need to look both ways before crossing a busy pandemic. And those are the two elements I was concerned about in the early going, remain concerned about now, and have been advocating for throughout the pandemic. That we really need to think about total harm minimization, not just preventing infection. And the best way to get there from here is by risk stratifying the population. So I start with this image of the social determinants, not of health, but of death. And that really was the transformation I was concerned about in the early going of the pandemic. This is from Health Affairs, as you see. So we speak routinely about the social determinants of health, and those are things like people's economic stability, food security, access to crucial goods and services, all the stuff that plays out in social and physical environments around us that makes our days okay or not okay. And I was very concerned that indiscriminate lockdown, without regard to people's risk of adverse outcomes from SARS-CoV-2, could translate into a wide array of devastating harms, increases in desperation, depression, food insecurity, hunger, domestic violence, child abuse, suicide, on and on it goes. And let's remember that at the start of the COVID pandemic, we were really just beginning to exit from what was the public health crisis of the day prior, and that was the opioid crisis, which, by the way, has clearly worsened during the pandemic. So more people are turning to drugs and alcohol as a way to escape the anxieties of the day. So I was very concerned about this very phenomenon, that there would in fact be social determinants of death. And so when I opined fairly early on in the New York Times, that's what I talked about. I was in no way suggesting that we disrespect SARS-CoV-2 or the potential that this virus had to harm us. That was very clear. It was equally clear, however, that it wasn't a one-size-fits-all threat, that in fact, older people, people with chronic disease were highly vulnerable to adverse outcomes, younger, healthier people, very much the contrary. This tended to be an extremely mild disease. And by the way, the epidemiology continues to reaffirm that to this day. So there were some people who were more likely to be harmed by infection, and others who are much more likely to be harmed by indiscriminate interdiction. If we shut everything down, we were going to hurt other people. And essentially my platform, and it shocks me that this was in any way controversial, although ultimately I guess these days anything can be, was that any which way the pandemic harms someone is bad, and any which way we prevent the pandemic from harming someone is good. So the idea that we should be aiming at total harm minimization seemed to me nothing more than self-evident. So I wrote about that in the New York Times, and someone else had a similar impression, and that was Tom Friedman, whose name you doubtless know, three-time Pulitzer Prize winner, long-term columnist at the New York Times. Tom was very intrigued by my ideas about pandemic management. We conferred. We've since become very close friends. We correspond all the time. And he channeled my thinking in a number of his columns, which gave them significantly more exposure. And I was consequently drawn into the vortex of pandemic response. And it was really difficult to manage my day job through all of that. But essentially what I was advocating, and what I was advocating with a much greater megaphone, thanks to Tom, was total harm minimization by means of what I called vertical interdiction, what has recently been called focused protection in the somewhat notorious Great Barrington Declaration, but which effectively is a risk stratified approach. Match the protection to the level of risk. Don't overprotect people where the remedy is apt to be worse than the disease. Don't underprotect people who are highly vulnerable to adverse outcomes. And frankly, that risk stratified approach is how public health responses, public health policy typically work. It's how they should have worked during the pandemic, and it's not too late to make them work that way now. And the basis for this really is pretty compelling. I was privileged to do a webinar in Berkeley during the pandemic with Nick Bloom, who is an economist at Stanford. And it was Nick who shared this slide with me. He cited this primary literature showing that for someone who loses their job, around midlife. So here it says age 40, but anytime around midlife for an extended period of time. So in other words, your job is gone, it's not coming back, to borrow from the boss, Bruce Springsteen. Uh, there is on average a loss of 1 to 1.5 years of life expectancy. That's massive. And this is mediated, of course, via the social determinants, disruptions in all manner of security and financial stability and so forth. Well, at the time that I was weighing in about this, we had about 200,000 deaths from COVID in the United States. That number tragically has doubled since then, and we can talk more about the implications of that in the Q&A as you all choose. But let's just go with the 200,000 number we had back then, just to make the comparison I was making when I put this slide together. And the CDC has estimated that there's an average of 10 years of life lost each time someone dies from COVID. Frankly, I don't think that's entirely correct, and I'll tell you why in just a second. I think it's less, but let's do that math. So 10 years of life lost, tragically, for 200,000 people, or now even if we jump up to 400,000 people, well, that's 2 million years of life lost, or if we use the current number, 4 million years of life lost. That's a huge sum. That's pretty staggering. On the other hand, the US has lost over 50 million jobs, and the estimates by economists I've spoken to are that half of those aren't coming back. So, if we take even just 20 million long-term job losses and do that math and multiply that by a year and a half, that's 30 million years of human life lost. That's a toll 10 times greater than the toll of infection. And I don't think we can ignore that. So I think a targeted approach to the protections required by this pandemic has always been absolutely crucial to minimizing total harm. Because if a year of human life counts, it always counts. If losing a year of human life is a tragic loss, if we know how to prevent it, well, that's true whether it's by means of infection or by means of haphazard interdiction. I think, frankly, nothing more arcane than decency requires us to think that way. That the means by which human life is truncated don't dictate the magnitude of the tragedy. And this also reverberates through our general thinking about pandemic response. Early on, this seems like lifetimes ago. It's amazing how a pandemic warps our perspective of time. But if you remember back in the day when the chant was flatten the curve, and this got a great deal of high-level attention in the media, and to this day, most of my colleagues in public health advocate for it. But I was very intrigued by this work. Maria Cecchina's University of Pittsburgh, Wes Pegden is at Carnegie Mellon. I connected with them early on. They wrote this piece in Medium. They're both mathematical modelers. And what they pointed out was if you go into the high-profile pandemic curves that argue for flattening, and you don't develop any new tools, you don't devise a new model, you just actually turn on the tool that's already being used to make the case for flatten the curve and show, well, what happens if days continue to follow one after the other? If you look at that top graph, you see that basically, the world stops in October. Well, the world doesn't stop in October. What happens after that? And their answer was, anytime you release the clamps, if you're locking down everything and keeping everyone away from the virus, no one gets infected, no one gets exposed, no one develops immunity. Well, anytime people come out of their bunkers, everyone's vulnerable, and it all just explodes all over again. And look what we've seen all over the world. Every time people have come out to daylight, because we had no systematic approach to risk stratify the population, we've seen massive spikes, massive surges, exactly what Maria and Wes predicted in this model. So they argued for honesty in pandemic modeling, and I conferred with them extensively in the early going. And then I told you, I don't entirely believe that 10 years of life have been lost on average with the tragic toll of COVID, and that's because I've been to the front lines. Admittedly, I didn't spend a lot of time there. I did clinical care for 30 years. I'm now focused on other aspects of public health and medicine, and I'm not seeing patients, but I came out of retirement to volunteer in New York City, did a number of shifts in an emergency department in the Bronx during the surge there. And what I saw was ambulance after ambulance bringing in desperately ill people with COVID from nursing homes. And to put it fairly bluntly, having been an ER doc back in the day, this looked a lot like any given day in the emergency room, all the same people, about as sick as you'd expect them to be, just we had a different name for what was wrong, but this is a population that's very prone to come to the emergency room, be hospitalized, wind up in the ICU, and die. These are very old, very sick people. We also saw younger people coming in who, oh, by the way, had COVID, and they were there for a headache or to have a laceration sewn up or whatever it may have been, but most of them were not very sick. So, what my frontline experience told me was massive risk differentials related to COVID, massive opportunity to address this whole crisis that way. So again, the platform that I'm advocating now is the platform I advocated at the start. Alas, there was more opportunity to put it to good use in the beginning than now, but it's never too late to implement a reasonable idea. And that reasonable idea is we should aim at total harm minimization. And the best way to get there from here is to risk stratify. So the objective is to minimize the total harms of lockdowns and of viral exposure by means of vertical interdiction or risk stratified interdiction. I like hierarchical responsibility, and that means the government needs to do its job, institutions need to do their job, but we also should empower individuals to understand their personal risk, the risk in their immediate network, and tell them something about how they can mitigate that risk and manage it. I think one of the great travesties of the pandemic is we have so effectively disempowered people with an endless barrage, not just of grim data, but of drama that make the data even grimmer than they are. And at almost no point along the way have we said, by the way, most of what makes you vulnerable to bad outcomes is modifiable. If we show you what's putting you at heightened risk, we can lead you in the direction of lowering that risk. There is something you can do. That's an incredible balm for anxiety and potential protection against depression and many of the ill consequences of these social effects. And then again, I think if we have hierarchical responsibility, there is a shared responsibility for mitigating risk. To some extent, it's mediated by policy. To some extent, it's mediated by what individuals can do. And I'm a preventive medicine specialist. We talk about teachable moments for individuals. All too often, that's the aftermath of calamity. Someone's had a heart attack, they've had a stroke, something horrible's happened. Suddenly they have religion. Doc, tell me how to take better care of myself. And, we regret that all too often that comes after the crisis. For the body politic, it seems to be much the same. So we've been neglectful about the massive burden of chronic disease in America for a very long time, but the massive burden of chronic disease in America is a huge part of the explanation for the very high pandemic toll. And so we now have an acute reason to address our chronic health. We can derive an acute defense against COVID, and then chronic better health is the gift that keeps on giving. So we can extract longitudinal advantage from that as well. We could do with better data even now, although at this point we have so many data from so many sources, we can effectively construct this pyramid I argued for many months ago. I thought we should build it with representative random sampling. Who's been exposed to the virus? Who's developed symptoms from the virus? Who sought medical attention for the virus? Who wound up hospitalized? Who wound up in the ICU on event or dying? And by means of this data pyramid, which we could have climbed to get up into the light and seen above this from altitude, we would have understood the epidemiology of SARS-CoV-2 far better than we have these long and grueling months. At this point, we never put the data pyramid together systematically, but we have approximations of it. And what they allow us to do is risk stratify the population. This color-coded grid is mine. It's crude and simplistic. Basically, as you see, I've got age tiers across the top and chronic disease burden along the side. And then I color-coded the tiers. Just think how empowering it would have been if at any point along the way, we had an easily available resource where people could have found out, here's the cell you're in. If you're in that crimson cell A, you're at very high risk and you absolutely need to shelter in place. If you're in cell I, you're at extremely low risk and can go about your business as long as you're not at risk of interacting with someone in cell A or B or D and exposing them. We could have had policies matched to levels of risk. And I think we should. I thought we should at the beginning. I think we should now. But as I say, my color-coded risk matrix is pretty crude relative to what my friends at Everest have put together. There are a number of tools available to enumerate COVID-related risk, but nothing I've seen is remotely as elegant as the CARC, the COVID age risk calculator that Everest has devised. And they'll show you exactly how this works, and you'll see how interactive it is, how accommodating it is of information you have or don't have, whether you fill in a field or skip it. But effectively, this says, given information about your age and your health, we can tell you what your risk of hospitalization, ICU admission, or death would be if you get this bug. But I think even more importantly than that, and that's already important because, essentially we're pulling a risk out of the shadows where it's terrifying and saying, no, we can quantify this. And by the way, you can compare this risk to other risks that are familiar so you can get a grip. And that's really important to people's mental health. But you're also going to be shown exactly what the sources of your heightened risk are. And as mentioned already, most of those are modifiable. There is an enormous opportunity to use this resource for policy at this point in the pandemic to determine who gets the vaccine when it's available, where people are in the queue, and not just in crude risk categories, everybody over 65. Not all people over age 65 have the same risk. We can risk stratify within risk tiers. That becomes less important when the vaccine is everywhere for everybody to get if they want it. But it's absolutely crucial while vaccine supplies are as rate limiting as they are now. So this should be used to guide vaccine distribution, but it also should be used as the bedrock beneath health promotion campaigns mediated by individuals and their families, but also by employers, by states, ideally by the federal government at large, where we say we can help everyone understand their modifiable risk factors for adverse COVID outcomes and empower them to do something about it. And frankly, I think there is enormous relief and benefit immediately just in the empowerment of understanding, and then a great deal of additional benefit that ensues by using this tool effectively in policy.